So they asked me this year to cover this, I would say, probably quote unquote interesting topic, but it's rather unusual that this is actually discussed. So they asked me to cover this, and I decided to accept it because it's as I said, not something is usually covered, but there's been a lot of work on the role of MRD, minimal, measurable, depends how you mentioned, residual disease in indolent non-Hodgkin lymphoma. So I decided to do it, and I covered almost exclusively, both in the text and the presentation, follicular lymphoma, which is obviously the most frequent disorder we're talking about in the field of indolent non-Hodgkin, and the one where we have the data. So I focus on that. So what can I say? I mean, first of all, that minimal residual disease can be monitored, but not in all cases. So that is one of the first points that I think we should underline, because the genetic lesion is not present with the tools we have today in every single case. Where we have it, this can be used to monitor minimal or measurable residual disease, MRD. So I've covered more or less different aspects and how MRD monitoring can be of value clinically, but that's what we want to know really. So I covered different topics, how this can be valuable, the amount of MRD you can detect at diagnosis in the blood and marrow, and how that can impact on response to treatment. So it's been mainly MRD and treatment and outcome. Now, not to make it too long, but just to summarize a few points, I think it's worth saying that in general, there's evidence in different settings that this is exactly the case, that we in fact seen that this can be of value in different situations. So what I did, because actually that's how Ash wanted to organize the session, I started with 2 clinical cases because they wanted to do it rather interactive in a way. So they asked us to present a few cases. So I prepared a couple of cases which I thought were relevant to the topic I was planning to cover. These are real cases, obviously. And based on that, to be a bit more precise, I tried to cover 5 different MRD-related topics. So one I mentioned is a tumor burden at diagnosis. Is that useful to stratify patients in different risk categories? Then I covered, can MRD refine the degree of clinical response to treatment? Is that in a way? And the third point I covered, can MRD predict progression-free survival? So it's a third clinical endpoint of potential MRD monitoring. And is another point, if we do different molecular testing over time, is this of clinical relevance? Rather than doing only one test, if we do more. And the other, which is obviously one of the key points in general in the field of minimal residual disease, is can we use MRD to personalize, to modulate treatment? So could that be an indicator of different treatment? So I won't go in detail of all of these because that's obviously quite extensive. But the bottom line is that in general, I think it's fair to say that MRD, based on data that have been published, and it's interesting here that the first data go back, let's say, I would say more than 20 years. So it's not a last minute aspect that we've been investigating. In fact, I remember we started when I was still in Torino, north of Italy. And I think our first paper was, if I remember well, published, in fact, in Blood in 2002. So it was published in 2002. You can imagine the study had started years earlier. So it goes back 25 years or so. And interesting point, despite the fact that we started working on this aspect about a quarter of a century ago, today MRD is still not used routinely in a clinical practice. It's not an agreed prognostic marker that should be used. I think it's important to say it's not in the guidelines on let's say the recommendations, although the data are quite compelling in different areas I mentioned. Then going towards the end, I tried to discuss how things are going to change because, as I mentioned at the beginning, not in all cases we have a marker that we can monitor molecularly for MRD. So now we're trying with more sophisticated technology to see if we can utilize the technology to have a marker for a broader proportion of follicular lymphoma patients. Then the other, one aspect I also mentioned at the end is, again, the technologies are evolving, and another one which is becoming rather widely used, although again, not still an indication in general, is that of the so-called plasma DNA. So monitoring circulating markers in the plasma of patients. So we're not talking of testing a marrow or blood, but on the plasma, which in lymphomas in general is of interest, more I would say in aggressive lymphomas than in indolent lymphomas, because the plasma, the circulating DNA could offer a better picture of the genetic landscape of individual patients. Because if you study, for instance, from a genetic point of view, the lymph node that you're biopsying, that's one lymph node. But the lymphoma, I'm speaking in general, not specifically here on indolent. But the lymphoma obviously can impact or involve different lymph nodes. And if you do, as we all do, a biopsy in one lymph node, that may not mimic the whole scenario, the genetic landscape of that given patient. Now, if the genetic abnormalities can go from the lymph nodes, plural in general, into the bloodstream. So in theory, you can have more data in plasma DNA. And this has been shown in aggressive lymphomas, not in indolent. But I just brought this up to say how technologies are evolving over the years. And as I said, just to finish, I think I conclude that it's not in routine clinical practice, MRD monitoring in indolent lymphoma, follicular lymphoma, saying, although there are many studies, in fact, that are using that to modify treatment. We've done it in localized indolent lymphoma, and we are modulating treatment according to the presence or absence of MRD in the patient who can be monitored. So this in clinical trial is certainly something widely done. It's not in the day-to-day clinical practice yet.